here in the United States of America. We're located in Central Florida. Currently, we have our offices in Central Florida, and we are about a 45-minute drive from the Orlando airport. And Orlando airport is the busiest airport in the world. We have in Orlando the most number of tourists. The number of tourists going to Orlando every year was topping out around 74 million tourists or visitors per year to Orlando, far more than Paris, France, which came in at second. So the Orlando International Airport is where you would fly in if you wanted to have surgery at Deuk Spine Institute. Now, this particular patient flew in to the Orlando International Airport, and she comes from Canada. We have many patients from Canada. We take patients from all over the world, and we're happy to help people with back pain because back pain occurs all over the world. It's ubiquitous in every country, every state, every region. And the treatment for back pain, the definitive treatment to cure back pain or neck pain, unfortunately, is here in Florida at Deuk Spine Institute. Are other surgeons able to cure back pain? If you have chronic back pain from a herniated disc, there really is no surgery to cure that pain except for what you're about to watch today, the endoscopic Deuk Laser Disc Repair. The Deuk Laser Disc Repair is the only surgery in the world that has been peer-reviewed and published for the treatment of back pain or neck pain. Other spine surgeries are performed to treat things like spinal stenosis, which does not cause back pain, and myelopathy, which is spinal cord dysfunction. It does not cause back or neck pain. Radiculopathy, which does not cause back or neck pain. It causes leg pain and arm pain. And then instability. And what is instability? Instability was originally defined in spine by two orthopedic surgeons, White and Punjabi, and they defined spinal instability as severe pain or neurological compromise, which means pinched nerves or spinal cord causing dysfunction of those nerves and spinal cord, with normal physiological loads. What does normal physiological loads mean? Well, it means that you're doing normal activities like walking and sitting and standing and bending, normal physiological loads that cause pain or neurological compromise. That is the definition of spinal instability. And that has been the definition accepted for years and years and years. However, that definition is changing, and it should not change, by the way. It should remain the White and Punjabi definition. However, the insurance companies who don't want to pay for spine surgery are starting to change the definition on their own. And they're changing it with the assistance of certain empathetic surgeons or doctors. And they're changing it to structural findings. And structural findings never really tell you the whole picture. Structural findings are not the right way to define instability. Because people have structural findings and yet they have no symptoms. So would that spine be unstable if you have scoliosis, but you have no pain and no neurological compromise? No, that's not true instability. So the truth is that true spinal instability must have symptoms or findings on the exam, and the exam being the examination of the patient, not the MRI exam or the X-ray exam or the CAT scan exam. So I adhere to the White and Punjabi definition of spinal instability. Once again, that is severe pain or neurological dysfunction that occurs with normal physiological loads. That's normal activities of daily living. All right, we are going to get started. Our patient comes from Canada. She has had a fusion done by a surgeon. Dr. Deuk Majan here. How are you? Are you ready to get started? Are you comfortable? Good. Your neck's comfortable, back's comfortable? All right. Now, what'd she say?
She said she feels better than she did in a long time.
All right, good. Well, I'm glad to hear that. That's what anesthesia does for you. But we're going to fix you permanently, so when the anesthesia's gone, you're going to feel great. I need your help, okay? You've watched this surgery from Canada. That's how you found out about the Deuk Laser Disc Repair to cure your back pain. But I need your help here. I don't want you moving around. I want you to lay still. If you feel any discomfort, just say ouch, and I'll give you some more medicine, okay? All right. I'm going to keep you awake for a little bit, and then I'll put you to sleep. What'd she say?
What's not coming through, honey? Oxygen?
You may not feel it blowing on your face, but there's oxygen, okay? But we'll check it. You're going to feel a little stick and a burn. That's normal, okay? Don't worry about it. Don't move. I'm just putting numbing medicine, okay? Now let me ask you a question. Where was your fusion surgery done? Was it done in Canada or the United States? Calgary? All right. Yeah, I apologize. That's me numbing your skin up. That's going to make it feel a lot better, I promise. I promise. I apologize. It's uncomfortable. I don't think we'll need more. So I've given her a little bit of lidocaine and marcaine. And that purpose of that is just to numb up the skin. Because really, where do you get pain in the human body? Not every structure you can feel pain. So there are pain fibers located in specific parts of our bodies where we can actually feel pain. And one of those is the skin. The skin has lots of pain fibers, okay? Because we want to know if there's a problem affecting our skin, that's the outside of our body. You basically, if you have a castle and you have a gate, you put guards by the gate to look outside and see who's coming, right? So the nerve fibers in the skin are like those guards. They're kind of paying attention to what's going on in the outside world. Are you doing things you shouldn't be doing that could harm your body? So she had a fusion done with screws and rods in Canada. And I can tell you there's several problems with this fusion, okay? To me, the most important one is that the surgeon did not put a spacer in the L4-5 disc. They did not clean out the disc. They did not put a spacer. So they actually left the disc in there, which was a mistake. It should not be done that way. But there are a lot of surgeons who do surgery badly. Shot? I would never do that. I always take the actual disc out, clean it out. It's rare that I would ever not do that. Shot? We need a lateral. So we're going to access the L5-S1 disc first. And we're doing this in a transforaminal approach. So what makes Deuk Laser Disc Repair different? Number one, we have a very small incision. The smallest surgery incision possible. It's 7 millimeters. Number two, I get to the spine by going around the spine, not going through it. Every other spine surgeon goes through the spine. They take the bone and ligaments of the spine out. All right, let's see what we can do here in terms of improving that. That's not a horrible image. Let's see if I can make this work. Shot. Let's see what you can do to improve 5-1. I know it's kind of hard, but yeah. I'm going to focus for a minute, folks, just trying to access the L5-S1 disc space. It's the hardest one to get. I think you need to wag a little bit. There's no point in me playing with this needle until we get a good lateral view. And I think that's much better. That to me looks really good right there. Yeah, I like that. I like that a lot. Okay. So the needle is actually right by the facet joint. And we're going to keep going. Shot. Yep. And I'm going to redirect medially, which I might end up hitting the facet joint. Shot. Looking good so far. Any pain? Shot? Where? Give me an AP. In the back or down your leg? All right. So you can see from the X-ray, folks, there's screws and rods. So number one, the surgeon did not clean out the disc. You could see on the X-ray, and did not put a spacer in there. That's bad, okay? The reason for that is very, very interesting. It's actually a biomechanical reason. If you don't take the bad disc out that's incompetent and bad during a fusion and put a spacer in there made out of PEEK or some type of a strong enough inner body material, I use PEEK, which is polyether ether ketone, then what happens is after surgery the patient gets up and their spine kind of sags down at L4-5, and the only thing holding it up really is the disc that's there, which is already painful, and then of course the screws. And the screws are not meant to hold the weight of the body up. Shot? Shot? So we're right at L5-S1 here on the right side. Any discomfort in your back? Shot. Where? That's where it's supposed to be. Oh, perfect. Okay, so when this patient contacted us, she said, my back's been hurting for a long time. I had a spinal fusion, and it still hurts, okay? So here's the dilemma. Why does her back still hurt? Well, could it be the discs above or below the fusion? Yes. Could it be the disc where the fusion was done? The fusion was supposed to take away that pain, but it didn't work. They didn't do it right. So they never cleaned her L4-5 disc out. They never reamed it out, cleaned it out, got rid of it, and put a new spacer in there. They just put the screws and rods in and did a fusion in the back of her spine. That's the one fusion that works well, it doesn't work well at all. It's called the posterolateral arthrodesis. So what I do when I do fusions, I do inner body and I do posterolateral combined. So it's a combined anterior inner body posterolateral arthrodesis. That has the highest success rate of getting rid of pain. But this surgeon didn't do that. They just left the disc in there. Bad idea. Because they left the disc in there, now this patient has pain, I believe, coming from that disc. And we're going to find out today. This is actually a very unique surgery you get to watch today, because it's not often that we're doing surgery on a... Did that hurt? I'll give you some more numbing medicine, okay? How come the light is so bad here?
Can you turn on that one, please?
You feel anything? No? All right. When I made a little incision and you seem to have felt it, so I'm going to numb things up a little more. You feel that, huh? All right. Who's talking? Is she concerned? No, everything is fine. You're doing great. About her what? Oh. You've got a real anesthesiologist here. You know, you don't see those very often anymore. Everyone's trying to save money and go cheap by hiring nurses as anesthesiologists. Yes, even in the United States, believe it or not. Especially in the United States. Hospitals are really being forced, in my opinion, by insurance companies to lower their costs, and to do that they are hiring nurses to do anesthesia. I love nurses. My mother is a nurse. My wife is a physician assistant. My sister's a nurse. I have so many nurses I know and care about, but I don't think a nurse should be doing anesthesia, at least not most of them. There's a few that are exceptional, and I admit that, okay? And I'll be honest with you, there's a lot of bad doctors too. I'm not just picking on nurses. There's bad X-ray techs, there's bad doctors, there's bad surgeons, there's bad nurses. You know, I used to believe everybody was well-trained and equal, but no, that's not the case. I can promise you that. So unfortunately, the reality is that there's a very big discrepancy between doctors that are really good and those that are not so good. Shot? So now we're going to try to make our way into the disc that was supposed to be cleaned out, but was never cleaned out at L4-5, okay? Shot? So I got to get past the screws and rods to do that. And this is where it could get tricky. Where do you feel that? Where? In the back or down your leg? AP? So the nice thing is our patient is, her spine is really close to her back, her skin. So I don't have to go very far to get to the disc. There are some patients whose spines are really far forward. Yeah, so I need to go more medial. Blood pressure's good, yeah. Okay. Shot. Let's go back to a lateral shot. Let's go back to a lateral view. Now, I always try to do these surgeries with one incision or one cut, but sometimes I cannot. Sometimes I have to do more than one cut. And the patients honestly don't care. You know, it's a 7mm incision. They'd rather have the surgery done properly with 2. Shot? Where do you feel that, dear? What's she saying? You feel it? All right, I'm going to give you some numbing. That's where your old scar tissue is from your old surgery. I'm going to numb things up a little bit and make it more comfortable for you. So sorry about that. I just use a little bit of Marcaine, right? No epinephrine, just Marcaine with some lidocaine in there. Yeah. We're not close to the nerve root yet, but we're getting there, so I can't add any more deeper than this, so I'm not going to. But this is the farthest shot that I'm going to do that. Where do you feel it? Shot? Okay. All right, well, like I said earlier, your spine, AP, your spine is so close to your skin, it's amazing.
She said now it's going down her leg.
It's going down your leg? Which leg? Right leg? All right, let's see where we are. All righty. Let's go back to a lateral. Do you still feel it down there? Huh? I can't hear her. Okay. Well, I'll redirect anyway. Go ahead and take a shot. And you're pulsing, right? All right. That's all your scar tissue, by the way, that I'm going through right now. Yeah. From your fusion. Man, we're getting it done, though. That's the good news. We're getting it done. Yeah. So as I go through the frame and I go slowly, now we're up against the back of the disc at L4-5. I could feel it. So I can actually feel it. You okay? The big tear in there. Shot? Yep. Yeah, I bet you can. That's incredible. We're almost done. We're going to be able to put you to sleep and then do your surgery soon. I just want to see if I can get everything done with one little incision, or do I have to make 2? So this time will tell. Any questions, Sean, from our audience? Sean?
We do have a couple.
You have a couple? Hold on a second. Let me just figure this out for a moment. Sean? Okay. Sean? Just lay still. You're doing really good. I know. Just lay still. Sean? We're navigating around all your hardware. Yeah. You have screws and rods in here, Sean. So I gotta get around them. Where do you feel that? In the back? AP? Yeah, we're nowhere near the nerves. AP? Just relax. Everything's going perfect, okay? It's going to be fantastic. You're going to feel like a new woman when we're done. How long have you had your back pain for? How long? 2006? When we had the housing crisis? I'm not happy with L4-5, that's for sure. Let's go back to a lateral. That's a good picture you got there, by the way, Jordan. Huh? Oh, sorry. I apologize. All right, let's see what we got. We need to go more medial. Oh, it's kind of hard to say because there's some rotation there. I mean, I can feel the disc for sure. Shot. Give me an AP. So we're dealing with a little bit of scoliosis. This patient has some twisting of her spine. And, all right, so right there we are pretty much at the pedicle, right where the disc is. So that actually looks good. Go back to a lateral, please. Yeah. And you can see the tip of the 4-5 needle is just where the pedicle is, where the screws go in. Yeah, I think it looks good. Let's see, that would be this guy. I feel like I'm in the disc. Sean? Yeah, we're in the disc. All right, let's see if we can get this last one done. And then we're going to put you to sleep, okay? Oh, maybe I need to go just a little bit more medial. Sean? I feel the facet. That's what I want. Where? Don't move. Where do you feel it? Where do you feel it? All right. Just relax. You're doing fine. Is it better? Let's see. So I'd like you to try to derotate 3-4. See 3-4? You see the level 3-4? Let's focus on that level. And you're going to have to do something with the orbit. Let me see it. Take a shot. She was moving a little bit. So we need to do something with the orbit. Either probably bring your side up. Let's see if that helps. All right, what we're talking about, folks, is the view with the X-ray machine. Okay, I think that's maybe better. I wonder if we overshot though. How many degrees did you move? 6? I think you need to do 4. So come back 2. Let's see what happens there. No, that's worse. So let's do another 4, the original direction, and see what happens. Yeah, that's better for sure. Okay, so for those of you paying attention, listening, you cannot navigate to where you have to go in the body with this procedure unless the X-ray is done properly. So the truth is the spine is twisted in every human being in different ways, and we have to adjust the X-ray externally to get the proper view of the bony anatomy inside. Are you doing all right? You what?
She feels congested or not.
Do you take any medicine for anxiety? What do you take? I didn't hear what you said. Okay. All right. Did you take that today? Well, there's your answer right there. So, yeah. Yeah, so great teaching point, Sean. And that is, a lot of people don't really understand or even pay attention to how important anxiety is in patients with chronic pain. Hey, take it easy, you're fine. Sean? AP? You're fine. So what I mean by that, folks, is that anxiety itself does not cause pain. However, anxiety has a tremendous impact on how pain is perceived by the patient. What does that mean? Well, it means that people who are not anxious, so we're just around that screw that's giving her a fit. Let's go back to a lateral. People who are not anxious, the pain they feel and perceive and how they interpret it and how they respond to it is very different than people who have anxiety. So people with anxiety often respond more severely to pain. I mean, they always respond more severely to pain. Let's face it. And so just lay still. You're fine. Sean, I know. So, yeah. Unfortunately, you didn't take your clonazepam today, right? All right. So that's when I need my anesthesiologist to anticipate and assist me with sedating. You said she got some Versed? That's probably gone though. Yeah, yeah. Yes. So the only way he's leaving is with a ride or 6 hours post-op. Huh? So it's one of those options you're saying? Yeah, I don't want the patient leaving until I see him. What we're talking about is our first surgery is wants to go home, he's ready to go home, but I like to always see the patients before they leave and check on them and make sure they're doing well. So the first patient we did, he's doing fantastic, but when I came in here to do this surgery, he was still not ready to go, so my staff are telling me he's chomping at the bit and wants to leave. And I don't blame the patient for wanting to leave, but I'm not ready to go see him yet. All right, let me know when you've got her a little more comfortable. All right, so we were having a nice discussion about anxiety and how it plays into pain perception, okay? It's not her fault she has anxiety, and I'm not going to point any fingers, but I'm going to talk to you a little bit about anxiety and benzodiazepines. Benzodiazepines are a class of drugs used in medicine. They've been around for over 100 years. They include common drugs like Xanax and the medication that this patient may be on. So Xanax is alprazolam, and alprazolam is a very short-acting benzodiazepine, whereas there are other benzodiazepines that are longer-acting, like Valium. Some of you have heard of Valium. The duration of action of Valium can be 8 to 10 hours, whereas alprazolam is 2 hours. Alprazolam is the most addicting drug in medicine. And then there's an intermediary drug, which she's on, which is sort of an intermediary half-life, 4 to 6 hours. But the point is that when patients stop taking these drugs that they're on, these benzodiazepines, which are otherwise known as downers, on the street, and then of course in medicine we call them anxiolytics. So anxiolytics, lysis means to break up in medicine. Anxiolytics break up anxiety. So an anxiolytic medication breaks up anxiety. It destroys anxiety. That's really the original purpose. If you go back to psychotherapy and you study Freud, you understand that all human behavior is a result of anxiety, and fear. We all live with fear. And so our outward manifestation of our response internally to fear is behavior. Okay? And when the balance of fear gets to be too great in some people, they develop anxiety disorders, like generalized anxiety disorder, agoraphobia, or even panic attacks, a severe form of anxiety disorder. Lay still. We need you to keep your head down. It's not an invitation to misbehave. The problem with benzodiazepines is that they affect people's cognition or thinking, and they can actually cause irrational behavior that is out of their control. And so, although her anxiety is a problem, we could treat it with a benzo now, relaxing her, but it could also make her misbehave. And so a great example of everyday anxiolytic is alcohol. Alcohol works in very similar pathways and mechanisms as drugs like Valium and Xanax. So we like to avoid downers during surgery because the anesthesiologist wants to be in full control of the sedative nature of the treatment. And when you give somebody an anxiolytic during surgery, you are basically introducing a huge question mark into the management of the patient's level of consciousness, because every patient responds differently to the same drug and the same dose. And it's not just based on weight, it's based on tolerance. And we don't know what this patient's tolerance is because there's no way to test for tolerance in a patient to see what level of tolerance they have. So, we good? All right. Let's try this again. So we're going after the last disc, that's the L3-4 at the top. Now anxiolytics do not treat pain. They don't directly eliminate pain. If you're having, if you get your leg cut off and all you have is an anxiolytic, that's not going to fix your pain. You understand? It doesn't treat pain. Lay still. All it will do is reduce your anxiety and hopefully put you to sleep while the doctor fixes your cut off leg. Shot? But it will not take the pain away. And if you go deep enough, you go into anesthesia, general anesthesia, then you won't feel the pain. That's not where we want to be with this patient. Shot? Or any patient for that matter. You're doing fine. Okay, just lay still. Shot? All right. I'm going to try something a little different. Let me have some more num-num. I'm going to numb her up a little bit again and see if I can't go a little further north to get around this painful area. You're doing great, by the way. Watch out for that needle. What'd you say? What'd she say? Yeah. So sometimes they think I can carry on a conversation with them during surgery, which I can. But the reality is I want them just keeping quiet and just letting me know when they have a certain type of pain so I can get the surgery done. You're doing great, by the way. Shot? All right. So I'm trying to approach this disc a little bit higher up. Shot? Shot? And you can see there's quite an arch to the back. It's almost like the spine moves away. Shot? Let's get an AP. Any questions from our audience at this point? Sean? Lateral? So we are in the back of the spine at this point. We're passing through the muscles, and My target is the disc that's right above the fusion. Sean? You're doing great.
So we do have a couple questions.
Lay still. Yes.
One of our viewers on Facebook is wondering what would cause a disc to bulge in the first place?
Trauma. So what causes a disc bulge? Trauma. Just relax. You're doing fine. AP. Where do you feel that? Where? Really? Like lateral? I need a real AP actually. Give me a real AP. That's not a true AP. See the spinous process is kind of off to the side, to the right side? Try to, yeah. It's more of the rotation rather than the sliding. But that's fine. Go ahead. Let's see what you got. Nope, the other way. Other way, other way. You're going the wrong way. You're going the wrong way. Shot? Oh, interesting. I guess you weren't. Is the spine that twisted? I guess so. You're right. That is a true AP right there. I like it. All right, you can see where we are. Now go ahead and go lateral again. So what causes disc herniation, disc bulge, slip disc, bulging disc, herniated disc? Anything you want to add with disc except for discitis, which is a very rare condition. All disc injuries, all herniated discs, all bulging discs, all ruptured discs come from the same mechanism of injury. It's called an annular tear. It's where the is that leg better? Yeah, I mean, I'm nowhere near the nerve. I mean, we're way behind the foramen. There's nothing back here. It's all a result of a tear in the back of the disc that allows the jelly to pass through the tear and cause pain. All right. Yeah, I'm right on your facet joint. You're fine. You're fine. Yeah. We're almost done. Poor thing. All right, AP. So, remember, we use these live stream sessions to teach people about spine care. It's not just about spine surgery. It's perfect. Go back to a lateral. So any discussion we have with you, the audience, about spine care and spine issues is fair game. And right now we're talking about really the benzodiazepines and really the effect of anxiety on the interpretation of pain by the patient and their response to pain. And anxiety is it's like adding kerosene to a fire. When you get anxiety in a patient that has chronic pain, it only makes the chronic pain worse. It makes it less tolerable. It makes the patient more dysfunctional. And the anxiety should be treated, but really, folks, what needs to be treated is the source of pain. And that's what we do at Duke Spine Institute. As a matter of fact, this patient was referred to us from Canada by a pain specialist who oversees basically all the pain management for Canada, for a region of Canada. And this doctor, I won't say, but this doctor, Dr. Waddell, fine, why not? I don't think it's a HIPAA issue, believes in this technology and what we're doing to cure pain so much, he literally sends patients from Canada to have this treatment, to get rid of their pain. So there's nothing else that works. This is it. And that's why people travel halfway around the world to have this surgery done, because this cures the pain. Once the pain's gone, guess what happens to the anxiety? It goes away. Now, it doesn't happen overnight necessarily, but I mean, think about it. If you had to live in chronic pain every day, wouldn't you be anxious too? Sean? I would. And you want to know what people are anxious about? They're anxious about everything. Are you comfortable? All right, we're almost done torturing you. And then we're going to put you to sleep, and you're going to wake up and that pain will be gone, okay? So I want you to take a few deep breaths, get comfortable, and we're going to just run a couple of tests, and then we're going to put you to sleep. So once the back pain or neck pain is gone, or whatever pain the patient's having is gone, the physical pain is gone, they can really start to heal emotionally. They can heal intellectually. They can heal spiritually. And that's what this surgery is amazing, is that it gives people the ability to heal their lives. It's really not just about pain, but it's about how pain affects every aspect of their life and the people around them. That's what this surgery really treats. All right, now we do want to know for sure where her symptoms are coming from. We want to confirm that. Are you comfortable? I'll start with one that I'm not sure about. All right. Yeah, all right, so let's show you what we're doing, folks. We've accessed the herniations. There's 3 of them. One of them is actually a disc above her fusion. One of them is a disc at her fusion. And the last one is a disc below her fusion. Okay? And I'm just showing you the discs. I'm not showing you the bones. I'm not much of an artist, to be honest with you. But all 3 of these discs have tear in the outer annulus on the back on the right side. And that's allowed the jelly to push out through the tear and create what's called a bulge, a bulging disc, or a contained herniation is the other name for it. It's called contained because it's contained by the posterior longitudinal ligament. It's not contained by the annulus, okay? The annulus is compromised from through and through, in to out. There's a tear in the annulus, and the jelly from the center of the disc is pushed through the tear, and now it's sitting inside that tear, causing pain and inflammation every day, all the time. And it's activated by anything mechanical activities like bending, lifting, twisting, playing sports, anything you do during the day, aside from laying in bed, causes pressure on the disc. That's what the disc is supposed to be. It's a pressure absorber, and it pushes the jelly out through the tear. So you get these bulges, all right? And these bulges are extremely painful. That's where the back pain comes from. That's where the neck pain comes from. That's where the thoracic pain comes from. And unfortunately, doctors don't know this because this is a new discovery. And so we're the ones who figured it out years ago, and we've been treating it for years. But most doctors don't know about it, and they just say you have pain, you got to live with it. And they try treating it with medications, they try treating it with shots, but the only thing that works is to do the Deuk Laser Disc Repair and repair that tear. So unfortunately, we're going to have to do a little testing. Are you comfortable? All right. Don't jump off the table if you feel anything, okay? All right. How bad was that on a scale of 1 to 10? Huh? I'm so sorry. How bad was it, dear? Give me a number. 10? Is that where you typically get pain? That's one of the areas? Thank God we did that test and we confirmed. That was L3-4. That was L3-4 we just tested. You can see it on the X-ray. I'm so sorry. Calm down. You're going to be fine. I have great news for you. This is it. When you wake up in an hour from now, these pains will be gone for the rest of your life. So just bear with me for a little bit longer, okay? All right, I'm very sorry. So we just injected a little bit of dye into the L3-4 disc, and she jumped off the table. I mean, she tried to at least. Obviously, we wouldn't let her jump off the table. It's figurative, not, it's not literal. Now we're going to continue our testing process. So, you comfortable? Yes? All right. So I promise you we're going to put you to sleep soon. So we have yet 2 discs to test. How bad is that on a scale of 1 to 10? 8? Is that where you typically get pain? So guess what, folks? That's the fused disc. Look at it on the X-ray. They were supposed to take that pain away with their fusion. It didn't work. Why? Because they never addressed the source of pain. Look carefully at where that needle enters the back of the disc, where the black dye is. Right where it touches the black dye, that is the tear in the back of the disc that's causing her pain, and it's still there. How long ago was your fusion? Oh, so you said your pain started in 2006, 2007, so you had a fusion right away.
No, it actually started about 2004.
Oh, 2004 your pain started.
Yeah.
So you've been living with this pain for 18 years almost?
Yeah.
And prior to 2004, you didn't have any back pain? You were perfectly normal. It's amazing. You got a tear in your disc, an annular tear from trauma. Was there a car accident or something? Nothing that you can recall? So what probably happened was you probably injured your back a long time ago, even before 2004. You had the tear, and then any kind of minor stuff that you do can actually make the tear bad enough to go all the way through, and then some jelly squeezes. So it just happened that you became symptomatic in 04, 18 years ago. So you've been living with this pain for 18 years. And you went and had a fusion done. It didn't work, did it? Well, you have been blessed because you're going to wake up from this and your pain's going to be gone for the rest of your life. Isn't that amazing? And I say that to you because I've done this 1,300 times. How bad is that on a scale of 1 to 10? How bad? Okay, is that where you typically get pain? I'm so sorry. Just relax. It's okay. Okay, you're fine. That was a 10 out of 10. Is that where you typically get pain?
Yeah.
Okay. I have great news. We're done torturing you. We're going to put you to sleep, okay? The pain's going to go away, and when you wake up, it'll be gone. You're fine, sweetheart. You're fine. So she's having a panic attack as a result of the pain. Just lay still. You're fine. I promise you. You're going to feel a little burning in your arm. That's the medicine going in. That pain just precipitated a panic attack. That is amazing. That's the first time you'll ever see that in your life. A discogram causing pain that she typically has that precipitates a panic attack. I've never seen it in my entire career of 26 years. That's the first time. But that is as real as it gets. So if you think panic attacks and anxiety disorders are all nonsense, think again. They're real and they're precipitated by real physical problems. We're going to take the source of her panic attacks away. I'm assuming that the back pain is the reason she's having panic attacks. There could be another issue as well that's contributing, but clearly I just precipitated one. Okay. So it all starts to make sense when you start to understand the human body and how it works. Unfortunately, most doctors are in the Stone Ages when it comes to understanding back pain and anxiety disorders and problems that affect human mood. All right, we're going to start with 5-1. Let's see a shot. I'm going to go ahead and get started. She's asleep? Yeah. All right. So finally, she's going to have what she's wanted for 20 years, relief of back pain. She's going to have that today. That's a miracle, to be honest with you. All right, now blood pressure is good. I probably have a little, there's going to be a little bit of bleeding on her because she's had back surgery. So what happens is in people with back surgery, they end up having a lot of scar tissue from the surgery shot. That's not the surgery that I'm doing. It's a surgery that was already done years ago. She said she had it done in 2007. So that was 14 years ago. She had her fusion. And the fusion didn't work. You all heard her say that? Fusion didn't work, and now here she is. She's going to get these painful discs fixed. once and for all. And we're not even doing open back surgery. It's all going to be done with her 2 little cuts, 7 millimeters each. Outpatient. She'll be ready to go home in about 45 minutes after I'm done. Shot. It's truly remarkable surgery. Shot. All right, so I feel the dilator advancing into the L5-S1 disc. Nope. I'm going to take the guide wire out so I can appropriately place. That's why I never did roofing. I would have missed the nail. So I'm joking, of course. I actually grew up, my grandfather was a carpenter, a handyman in New York. He taught me a lot. I did a lot of special projects with him around the house. And I actually learned how to use a hammer and a screwdriver and tools as a kid, where most kids were just playing on big wheels. Shot. 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 Beautiful. Now we are going to have to make an incision for the L3-4 because I had to go at a different approach. I tried to do this one in the same hole, but it was like the trajectory, the area I had to go through. It would be like going through a very dangerous part of town where you could get mugged. So I kind of took a different street, a different path to get there that was safer and less painful for her. All right, good. We're ready to get started. You can all see Sean, the entire surgery is done through this little skinny tube, right? We're going to fix 3 discs. And let me just show the audience real quick for your own knowledge and edification that had we done this surgery as a fusion, I could actually cure her back pain with a fusion. Okay? If I was doing a fusion on her, the incision would literally be from here to here. This big, from here to here. You all see that?
Yes, we do.
That is a big, big, big incision, okay? And that would be really painful for months after surgery. This incision we're using is minimally invasive endoscopic surgery, is much smaller, and it's not going to cause pain for her afterwards, like a big incision. So she won't need narcotics and anxiolytics after this for the actual surgery itself. It's pretty much bloodless surgery. We've lost all the blood we're going to lose. We've lost probably like 2 milliliters, which is nothing. If you cut your finger, you bleed more than 2 milliliters. If you stub your toe, you bleed more than 2 milliliters. So we've lost just a few drops of blood. All right. So we're inside the disc. Why am I getting a bad view on this? Give me a Raytech. I'm going to clean the end and look at it and see if it's looks good. Yeah, that looks better. There must have been just some blood on there from going in. All right, here we are inside the disc. Take a look at that, folks. That's the red streaks right there are part of the inflammatory process. All right, so we're starting at L5-S1. That's the first disc we're going to work on. You have questions, Sean?
Yes, we do. One of our viewers on Facebook is wondering, Dr. Deuk, I'm a professional athlete and I have a very high threshold to pain. How would diagnosis and treatment vary for me?
All right, well, first of all, welcome to the surgery, live surgery, and you know, the truth is that whether you're a professional athlete or not, The diagnoses are all the same, okay? And there's 32 causes of back pain, 32 potential causes of back pain. And so for every human being I see, whether they're a professional athlete or they're a housekeeper, it doesn't matter. The causes of pain stay the same. All right, but what differs though for every person is that your cause of pain is going to be individualized to you. And if your pain is coming from a disc or two plus a muscle in your buttock, for example, or your tailbone, then you're still going to have a couple of those 32 causes of pain, and we just need to focus our treatment on what's causing your pain. So, great question. What it really speaks to is that no matter who you are, your cause of back pain will be one of those 32 causes of pain or multiple of those 32 causes of pain. And the only way to know for sure what causes your pain is for me to examine you and to see an MRI scan of your back. So with an MRI scan and a physical exam, I can diagnose probably 90% of people's back pain causes. And then for those 10% that I can't, based on the physical and the MRI, I need a little more information. I would probably do an additional test, which would give us that information. Those tests include discograms, joint injections, selective blocks, things like that. So we have the tools to do that, but I would need to actually physically see you in order to be able to do that. But whatever your profession is, we can diagnose the cause of your pain, okay? Whatever your profession is. And I can tell you right now, anyone that has back pain that lasts more than 2 weeks is really dealing with a herniated disc as the cause of their pain. Unless you have cancer of the spine or a tumor, a fracture, or an infection. Now, infections, tumors, and fractures of the spine are rare. They're not common. The most common cause of back pain is going to be a disc problem, a problem like this patient and the last patient we did earlier, a herniated disc. Can professional athletes have the laser surgery? 100% yes. And I'll be honest with you, had Tiger Woods come to me instead of getting a microdiscectomy first elsewhere, and then again another microdiscectomy, and then again another laminectomy, microdiscectomy, and then finally a fusion, I would have saved his entire career. I hate to say it, but it's true. He threw away 10 years of his career by going to the wrong doctors for his back surgery. 100% avoidable. I would have saved that man 10 years of his life of suffering and pain, and maybe even pain medication, right? Like we all know Tiger Woods got hooked on pain meds. I'm not his doctor, so I'm not releasing any HIPAA information on him. He never treated with me, but it's been in the news. Everyone knows he's crashed his car because of the pain meds, and his life's been ruined because of pain medication. Let's face it, his life's been ruined because the doctors that treated him. What's going on?
I'm sorry, I'm shaking all over. I'm having pain in my legs.
I need Anna here. You pointing door right here, same.
All right.
Yes, I can tell now. I'm okay. I'll be okay with it.
All right, how is she doing? She's doing okay? Let's let her wake up a little bit. Let's let her wake up a little bit. All right. So what I was saying, folks, is that unfortunately it was the misdiagnosis and mistreatment of his pain that I believe, that led Tiger to have all the problems he's had professionally and with respect to pain medication. All right, Sean, we're going to go offline for a moment. On the voice, you can just, I need to have a conversation here in the OR. All right, so we are just, I had to make a trade, a stock trade. I'm just kidding. So we're still working on the bottom disc, and we had a great question from one of our pro athletes watching. Just out of curiosity, what sport do you play?
They are a professional dancer and acrobat.
Ah, beautiful. Professional dancer. Well, yeah, like I said, the acrobats and dancers many times get back pain from disc problems, herniated discs. And a lot of times it could be a small disc herniation, so the doctor misses it and doesn't realize that that's the cause of your pain. But this surgery you're watching now would be the perfect fix. You will have to take time off of your profession. You're probably going to have to take at least 3 to 6 months just taking it easy. Doesn't mean you can't do anything. It means you just have to really limit your activities. And there are certain moves, obviously, that a professional dancer does that puts a lot of pressure on the discs. And so we would want to restrict those movements and minimize them. Remember, if you get your disc fixed, you can go on and have a normal life without back pain. You just got to let it heal. Okay, the recovery from the surgery may be only 1 day or an hour, but just because you're feeling good doesn't mean your disc is healed. And you could easily tear it again and re-rupture it. So that's what you really want to avoid in the recovery period and that healing period, is you want to let the disc heal completely so that it doesn't get re-injured. See this hole right here that we've created by removing the herniation and cleaning up the annular tear? This is going to get filled in with something called collagen. And collagen is your body's way of healing damaged tissues, except of course in the brain where you can't get collagen. But every other tissue and organ in the body is healed with collagen and elastin, connective tissue. And that's what you want. You want this to fill in with collagen. You don't want another herniation. Laser off. We're pretty much done with this level. All right, the nerve root is going to be right up there in that fat. And yeah, we're done here at L5-S1. So that was easy. We got 2 more to go. The next disc we're going to be doing, folks, is going to be the L4-5. That's the one that she had the fusion done back in 2007. So that was 14 years ago. And that was done again in Canada. I didn't do her fusion. I would never do a fusion the way this doctor did her fusion. I always put a spacer and I always put a crosslink. And this doctor didn't do either of those things. I always clean the disc out as well. So the doctor that did her fusion, in my opinion, did not do it right. Now I'm going to say something. Even though he didn't do the fusion right at 045, she still has pain above and below the fusion. So we call that adjacent segment disease. All right. All right, so let's go up again, Sean. How are we doing over there?
right, you're on.
Is that the shot right there? I apologize about the sound, folks, but we're having some issues we're dealing with and trying to address it. I am actually, Sean, passing by the fusion. So it's not really, I don't think it's fused once again, because if it was fused, there wouldn't be pain in this disc that she typically gets. And there's a lot of scar tissue, and it's a slow process, to be quite honest with you. So I can feel a lot of somewhat resistance from the scar tissue back here. And honestly, I don't really even feel bone. So the surgeon that did this surgery did a posterior fusion, a fusion in the back. And I'm passing by the fusion area right now, and I don't feel any bone. So I don't think this ever took. I don't think this fusion took. So we would call that a failed fusion. Shot? Shot? Don't worry about the phone. Let Zane deal with that. Shot? Okay. Taking that out. Shot? You're okay. Everything's all right. Just lay still. So as throughout the case, the patient will sometimes get lighter and sometimes deeper. The key is to just keep them in a state where they're comfortable. Shot. Just lay still, you're fine. Let's put her down just a little. Shot. Okay, take it. Shot. All right, we're inside the L4-5 disc. Just the slightest bit, by the way, not much more sedation. She should be okay for a little while. Let's,
Standby light.
any questions, Sean?
We do have one.
Go ahead.
A viewer on Facebook is wondering, why isn't common knowledge about spine health more related to other surgeons, or why aren't other surgeons learning this kind of stuff?
So, honestly, I couldn't really hear what you said. Could you repeat the question?
Yeah, the question was, the viewer just wondering, why aren't newer techniques being adopted faster, and why are a lot of surgeons not adept to pick up on new knowledge?
Oh, great question. All right. So the answer is complex. The answer is complex. So the truth is, in the spine world of spine surgery, there are a lot of new technologies being introduced, but for all the wrong reasons. Unfortunately, how's my irrigation? So I'm going to give you an answer that you won't hear anywhere else, but it's the truth. And it's born out of years and years of insight, studying the system and understanding the system and why it's truly broken. The main reason is greed. It's all about greed. And what am I talking about? Well, by the way, this disc is really bad. We're very oldly damaged. You can see all the scar tissue. So what am I talking about? Basically, what I'm talking about is greed on multiple levels. Greed from the companies that control the implants, like screws and rods and cages that are put into people's spines. They're making tens of billions of dollars a year in profits selling screws and rods and metal and plastic and artificial discs. and interspinous devices and spinal robots. Okay? And they're promoting these things to surgeons. And surgeons are honestly, they're very influenceable because where we train is at the university in the residency training. And their teachers are on the take from these companies, okay? They're getting paid millions of dollars in money to promote these equipment, these screws, rods, cages, things like that, artificial discs. And so basically the companies that control the sales have infiltrated the universities and teaching centers and are very involved in training the residents, the new doctors, the new surgeons coming out. And they're trained to do these very invasive, expensive surgeries with fusions and screws and rods, okay? That's one problem. Now, you'd think that the American Association of Neurological Surgeons or the Congress of Neurosurgeons would want to promote the more advanced technology, but they don't, because they're also controlled by the same spine surgeons that control the academic centers and the training. And all this comes back to money. The American Association of Neurological Surgeons and the Congress of Neurological Surgeons, they control the educational platforms for all neurosurgeons, thus spine surgeons in the United States and really the world. They are getting millions and tens of millions of dollars a year, about 30 to 40 million a year, donated to them from the companies that produce the implants. So it's a completely corrupt system where the implant companies that are like Medtronic, Sofmordanic, right? DePuy, J&J, Johnson & Johnson. Used to be Synthes, Stryker, Nuvasive, Alphatec. They all make such profits on selling screws and rods. They probably pay, I would say, maybe $50 for a screw or rod, and they turn around and sell it for $500 to the hospital. And sometimes we put in $10,000, $20,000, $30,000 worth of screws and rods. This patient's fusion would probably cost somewhere around $30,000 in screws and rods. So multiply the average spinal fusion, which is probably around $15,000 in implants, times 1.5 million. And that's how many fusions are done every year in the United States. It gives you an idea of the cost of and the profitability of the industry. Okay, so they have full control over the training of spine surgeons in the United States, whether they're orthopedic or neurosurgery. That's the problem. That's problem number one, is financial. With this surgery you're watching today, there is no screws and rods. There are no implants. I'm not putting metal in this patient. I'm not putting biologics. I'm not using a spine robot. I'm not using anything that is disposable or implantable. Do you understand? And what that means is that there aren't big companies making big profits off this. So they actually don't want this surgery being known. They've done everything to block it. I've brought this surgery videos and everything to the American Association of Neurological Surgeons, and they basically told the people in charge of promoting and distributing educational information, they said, don't distribute it. When I go to neurosurgical journals and I try to publish it, or I go to meetings now and try to publish it, they don't want it there. It's basically being blocked. So you can't really blame the surgeons entirely, though the surgeons are to blame as well, because the way I found out about it was I actually was offered to come watch an endoscopic surgery and go to Korea and go overseas to learn about how to do it. When I actually saw it done and the patient woke up and they didn't have any pain in their back or leg, I was amazed that this could be done. And so I went on and basically pursued an education overseas in how to do the endoscopic surgery. And over the years, I've developed my own technique that I think is better than what they're doing in Korea. See the tear right there? That's where the pain comes from. And I started to understand this disease of herniated disc and annular tear better and better and better. And it became my entire career, my entire life. And I started to really see results that were second to none with the endoscopic laser surgery. How are we doing on irrigation? You giving some more? How are our patients doing? Both? All right. So, number one, there's tremendous financial disincentive for surgeons and the industry to embrace this technology because there's no money in it for them, for anybody really. I make a lot more money doing fusion surgeries. So why do I do it? It's because it's not about me. It's about my patients. It's about giving them the very best, the safest, most effective treatment in the world with the fastest recovery. And that's what I take pride in, actually being a real doctor who puts the patient's needs ahead of their own. So that's number one. Number two is this is not, I make it look easy, but it's not an easy surgery to do, and there is risk, tremendous risk. And if the surgeon misses by a millimeter or two, the patient could be paralyzed, they could have spinal fluid leak, they could have lots of complications and problems as a result of the surgery, even death. So when I start doing surgery on the thoracic or the cervical spine, people can die, but they don't, because I'm very careful and I know what I'm doing, thank God. But the reality is that it's potentially a very risky surgery. So surgeons like to do what they're comfortable doing from where they were trained in their residency. And residency is a 7-year training process at a university. I'm not part of a residency program. I wouldn't mind it. I would love to be, but I'm going to be very selective where I go. Would I go to Harvard? Yes. Would I go to Oxford? Yes. Would I go to UC San Diego where I did my undergrad? Yes. Would I go to Los Angeles? No. Would I go to New York? No. So I'm the guy doing this surgery in the United States. Nobody else knows how to do it. And I'm not just going to go anywhere to train people. There has to be, you know, a good reason for me to do so. So we actually offer training here at Deuk Spine. It's called a fellowship. If you go to the website, you'll see we offer a spine fellowship to train people to do the surgery. And, you know, unfortunately, because the implant companies control really what the spine surgeons do in America and the rest of the world, they don't want this surgery out there. So they discourage them from coming here and learning. So you wanted the answer? That's the answer. It's a hard surgery to do, and there's very little financial incentive for people to do it, except for the patients. They want it. And that's why we do it. Ian, let's go off for a minute. Sean?
We are back on.
All right, folks. So we just finished the endoscopic surgery at the L4-5 disc, and there was. This is the area where she had her prior fusion done in Canada. So there's a lot of scar tissue, and the thing about scar tissue is that it takes blood supply to make it. And so when you go into somebody's body and do surgery in an area, that area that you operated on is going to get hypervascular for a while. Like a while is like a long time. Basically, the reason for that is the tissues need to heal, and to heal you need a lot of blood flow. So your body's response to that trauma from the incision and surgery, like a fusion that she had, would be to supply that area with a lot of blood. And the way it does that is it actually allows your body blood vessels grow into that area. So maybe there was like 5 blood vessels in this area before, but after the fusion there'll be 40 or 50 blood vessels. All right, and the reason for that is your body responds to that area of trauma by providing blood flow to go in there and heal the tissues. And the way your body heals is with scar tissue, collagen, okay? So I just got done coming in from the side, going around the fusion, but because the patient never really fused, there's always been this inflammation going on there. It's kind of like a callus, which is a scar tissue area that's raised up, and maybe you've heard of something called proud flesh. Proud flesh is basically inflamed tissue that just doesn't go away. So that's what she had. She had all this inflammatory tissue, not just in the disc where I repaired it, but behind the spine where her fusion was done. And so now that we've done the surgery and we've repaired the discs, I think that area is going to heal much better. So I'm applying pressure to the incision because what we're going to do next is, if you've been following the surgery, normally we would do all 3 discs with one little cut, but I couldn't get to the 3rd disc with the same cut, so we have to make a second cut, which the patient's fine with. We've already talked to her about it. But that second cut, I don't want to start it until this one I've made sure there's no bleeding going on in the muscle. And I can feel the muscle feels really supple. So it feels good, but I'm just going to wait another minute or 2 before I get started to make sure there's no hematoma. This would be a good time to take questions.
We do have a question.
All right.
We have a viewer asking, are the risks higher for this procedure or for a traditional discectomy / fusion?
Yeah, that's a great question. Are the risks higher for this endoscopic surgery versus a traditional surgery like a microdiscectomy? The answer is the risks are about 500 times higher for traditional spine surgery like a microdiscectomy, laminectomy, or even a fusion is probably 1,000 times higher risk. In 1,300 surgeries, what is that loud noise? Huh? Oh. In 1,300 surgeries of this endoscopic type that I've done over 15 years, we've had 0 complications, so no complications. The average risk of complication with a traditional spine surgery runs anywhere from 5% up to 50%. Depends on who's doing the surgery and what kind of surgery they're doing and the condition of the patient before the surgery. So, I mean, really, the risk of complications is massively higher in traditional spine surgery. Dr. Pettit, thank you. I'm not doing anything but holding pressure for another minute. We just completed 2 discs. We've had 5 cc's of blood loss. We're getting ready to do the last one, but I'm going to wait to get the green light from you before I do anything. Take your time. I had her stop the propofol and wake her up, and so she said, you know, saturating at 99%, that's fine. She does have anxiety, we were talking about earlier, and she takes clonazepam, which is also known as Klonopin. So we had to give her a little bit of maybe Versed or something. How's she doing? And this looks good. So I'm going to show you what we've done so far. We've made a 7mm incision. Can you see that, Zach, there, right there, in front of my finger?
We can see it.
And we fixed L4, L4-5 and L5-S1 discs. We've got one more disc to fix at L3-4, but we're going to wait until our anesthesiologist gets situated. No, you can put pressure, but I don't think it's bleeding. We're done. And we just need to do this last one, but I want to wait a minute until he's ready. Are you not getting a reading? Do we have another machine if that one's not registering? All right, we're just waiting a minute while our anesthesiologist gets situated with the patient. This would be a good time to ask questions, Zach. Take your time, by the way. No rush. Zach?
We don't have any other questions currently.
All right.
We have one just come in.
Okay, go ahead.
Viewer from Facebook is wondering, what's the efficacy of this procedure?
What's the efficacy of this procedure? The efficacy is for curing back pain and leg symptoms from a herniated disc is 98%. The average of 98% on average over hundreds of patients of eliminating the back pain and the leg symptoms. 98% for each one. So the complication rate is 0. I've had 0 complications in 1,300 surgeries. The recurrent herniation rate, the chance that the patient will have another herniation right where I did the surgery, is 1%. That's 1 in 100. That's actually better than other types of surgery like a microdiscectomy, where the herniation rate is higher, usually around 10%. Let me know when I can proceed. Let's get a shot. We're going to do the last disc, folks. If you're looking at the Xray machine picture, so you can see the screws and rods that are in there from her prior surgery. That was done 14 years ago in Canada, where she's from. I did not do that. No, we need a little pressure here. Again, we're going past the scar tissue. So I'm not going to make an incision until we're ready, but I at least wanted to get the needle out. Did that answer the question?
Yes.
How you doing, Pettit? Is it not reading respirations?
It's not reading our end tidal CO2.
Well, there is no end-tidal CO2 without a tube down. She's satting at 99, 98. So for the question about how effective is the surgery, every patient I've done, at least in the last 5 years, has really, their pain has gone away 100% from the disc. So their back pain is gone away 100%, their leg symptoms have gone away 100%. If they have weakness before they come here, the weakness is probably going to still be there after surgery for about 6 months to a year to heal. But the pain down the leg goes away right away. All right, do you think that's a reliable cuff pressure? Are you happy with that? Or do you want to... We're good? All right. Yeah, I mean, she's perfusing because I can see some bleeding here. So... All right, we're going to make our last incision here for the L3-4. Remember, I couldn't get to the L3-4 from the original incision because the angle was wrong, so I had to go through a different entry place, which is not typical. Typically, we can get all 3 discs with 1 incision. So, all right, so the dilator goes down, shot. We're going to follow this guide wire right past the top screw. You all see the screws there, shot. Yep, and we're going to go past it, shot. And we're going to go into the disc herniation, through the foramen, off to the side. Shot. Almost there.
We have a
Shot.
question.
Yeah, of course.
Another viewer from Facebook is wondering, will this procedure affect the discs above and below like a fusion does?
No. So the Deuk Laser Disc Repair does not change the biomechanics of the spine. We're not fusing. The reason that fusions can affect the disc above and below is because you're fusing joints that normally move. So there's more load on the joints above and below. Shot? Okay? So if I fuse 2 bones that normally bend, and every time you bend forward, they bend forward. Every time you bend back, they bend back. Every time you twist your waist, they're twisting. If you stop those 2 bones from moving, that's going to put more force on the next disc above and below. Go ahead. Go ahead. Twist it down. Come on. So the other reason fusions cause adjacent segment disease, go down, is because the surgeons frequently fuse the spine in bad alignment. They fuse it with kyphosis, they fuse it with scoliosis, and so the discs above the fusion or below the fusion have to compensate for the abnormal position of the fused disc because that fused disc can't move anymore. It's kind of stuck in that bad position, so the spine has to twist itself the opposite direction to accommodate. Think about it. When you're walking, do you walk sideways or do you walk straight forward? You walk straight forward, shot. When you're doing your activities of daily living, like walking, bending, twisting, running, playing sports, you don't do it with a side view. You do it head on. So if that part of your spine is twisted to the side, The other parts of your spine have to twist the opposite way to accommodate. And that's what causes adjacent segment disease. Sean? Perfect. All right. So we're rocking and rolling on our Canadian patient. And we're going to do the last disc, or we're going to get the fluoro out of here first. That's a great question, by the way. So with Deuk Laser Disc Repair, there is no adjacent segment disease. A little faster. There is no adjacent segment disease. Because we're not fusing. We're not putting any metal or plastic in the spine. We're not putting any biologics. Everything is all natural. We're just literally going in and repairing the part of the disc that's causing the back pain and the leg symptoms. And that's it. We're not adding anything to the spine. We're just taking away the bad tissue that's causing problems. Beautiful. So there's the tear. There's some granulation tissue. And it's a little out of focus, so I'll try to focus it for you a little better. Let's see. Maybe that's a little better. Dr. Pettit. Wow, what a surprise and what a pleasure. Are you vacationing in this area?
No, I was getting off the Apollo and I'm on my way to lunch.
Are you kidding? Wow. You are Superman for the day at least. Yeah. Superman. Thank you. Thank you very much. Thank you very much. All right. So this is our last disc. We need about 10 minutes max. We should be done. The other patient is fully recovered, wants to go home. I told him no. I want to go see him first. Of course, home is a relative thing. I mean, it's the hotel because he's from out of town. But I'm going to go check on him in a minute. Just about done here. What time is it? So Sean, it looks like we may actually still be able to make our meeting. If you're there, Sean. By the way, we've got wonderful mole when you get a chance. Dr. Pettit. I mean, if you like mole, have you ever had mole before? It's a chocolate sauce. It's got a little bit of heat, but it's really amazing. Chicken mole. All right, so we're inside this disc. I went right through the tear, right through the herniation, and we're just zapping it all away. This is all herniated disc right here, nucleus pulposus. Why am I seeing bubbles? You got to warn me when you change the irrigation. All right? Did you hear what I said? Yeah. Otherwise, we get charring. All right. Yep. I'm just seeing a lot of bubbles. Well, when you squeeze the bag, you can't let the water go down and the air bubbles go up. Otherwise, you're squeezing air bubbles into the line. And they end up right here in front of my eyes. Would you understand what I'm saying? Yeah, if you want to switch it, you can switch it. Go ahead. I'll wait for a second.
Are we good for the meeting?
Dr. Patel going to come do the piriformis?
Okay.
All right, so I'll be done literally. Oh. Why did the bubbles show up now? Huh? When did you send them? And you try to make sure there's no air bubbles going down the line, right? I think it's not making sense. Did you just inject a whole bunch of air bubbles down the line? Huh? No, not intentionally. It could be inadvertent. It's better now. Well, now I'm seeing more. All right. This is the L3-4 disc. I was a bit surprised that this was painful, to be honest with you. Yes, it looks abnormal for sure on the MRI, but her pain really localized more to the 4-5-5-1, and the 3-4 I thought would not be painful. But you know what's interesting is if you look at the arch of her back, the arch actually does something unique, and what it does is it clusters several discs closer together, right? So if you have the discs on a straight spine, then they're going to be further away than if it's on a curved spine, because the curved spine brings the disc closer together. And so this L3-4 disc I thought was too high, like on a normal spine, but because she's got really good lordosis and a curve, it brings them closer together. It brings the tears closer together into a more concentrated area of her back. That said, when we did the test with the discogram, it was clearly positive for pain, and it was definitely her typical pain she gets every day. She said it was concordant, meaning that's the pain she gets every day. So I was just a little bit surprised. There's some herniation right there. That's lateral. If you do this type of surgery, make sure you look lateral. It's a little bit complicated to understand, but basically we're in the lateral disc. We're out in the lateral foramen here. Okay? So I'm actually at the 6 o'clock position where where it's normally 6 o'clock. What is the suction going on? It's not this guy. It's just the bag?
Yeah, it is.
So the 12 o'clock position right there where all the laser blasts are, that's medial. That's the towards the midline of the body. And then this 6 o'clock position over here is lateral. That's where I was showing you that blue herniation a minute ago. All right, we're going to keep working our way out. My foot's getting a little bit wet. Now this disc here is more of a newer herniation. You can see because there's some fullness to the material. It's not as dried out. But there is a lot of the white stuff. They look like white caps. Those things are collagenized herniation. So that's part of the annular debridement, and that shows that this injury is older. Those things only happen with older injuries, typically 6 months or older. So the nice thing about looking inside the herniation is that you can actually age it. And a lot of herniations have more than one part. They have a newer part, an older part. This one has both. Ooh, look at that herniation there. All right, stand by. We call that a reverse herniation. And basically what it is when I went in, I shoved the herniation back into the disc, and that's one of the pieces of herniation that I shoved back into the disc coming out. I want to get those because those are what are causing her symptoms. I was going to say, I feel something tickling my toes. I thought we had a little raccoon or something running around the operating room. Come on. You have a question for me? Sean?
Not currently.
All right. I know this is taking longer than I told you, and I apologize, Dr. Pettit, but... Hey, now, come on. There we go. Yeah. I'm having trouble with the fiber. So we talked earlier about the amount of energy that we deliver with each burst. And I told you that we're really using this laser at about 1/3 of its capacity. And we could certainly ramp it up to a higher energy delivery. But what that does is it becomes more dangerous, and it causes a lot of damage to the tissues in the process, which we don't want to do. We don't want to be damaging the disc that we're trying to repair. So I think where we're at is perfect. And this is a holmium YAG laser, for those of you wondering what kind of laser we use. A holmium YAG laser is a special kind of medical laser. People always say lasers, they don't do anything, but if you look carefully at the metal tube, that's stainless steel. You see the blast marks from the laser blasts, and that's melted steel. So if a lot of spine surgeons who don't do laser spine surgery like we do at Duke Spine, they badmouth it and just make things up. And one of the things they say is the laser doesn't do anything. It can't really do anything to the disc. Well, you better believe it does. That's just speaking out of ignorance and jealousy, to be quite honest with you. Just about done with this disc. Oh, so annoying. Wipe that. Thank you. All right, let's just pull back a little more. There we go. You see the red at 12 o'clock? Those are blood vessels and fat in the epidural space. That means we're pretty much done. Just going to clean up a little bit more. And I'm going to say something while we're doing this. This disc is badly damaged, okay? And it's no wonder that it's causing pain. It's obvious to me. But I'll tell you, the MRI scan, if you look at it, doesn't look that bad. MRIs are not sensitive enough to tell you where the disc is injured severely. They're not good enough to tell you where pain comes from. MRIs just really kind of help a little bit structurally to see where there's a problem, where there's an abnormality. But really, it's the clinical exam and the experience of the physician that can really determine where your problem is, and then of course fixing it is a whole nother ball of wax. All right, 1 minute, I believe, unless something surprising happens here, which I think we've had enough surprises for one day. I will say though, the mole was surprisingly good. Make sure you get some on your way in the kitchen, seriously. All right, there you go. And you can see why it's so easy to re-injure the disc. Is we've debrided it and we've gotten rid of the herniation and we've cleaned up the tear, but you know there's still a hole there, and that's the way it is with microdiscectomy as well. There is no way to repair this annulus, and everybody that's tried repairing it has regretted trying, because whatever you stick down here ends up getting pushed out against the nerve, and then the patient comes back with horrible leg pain and you have to do a second surgery. So nothing has been developed yet today that actually seals this thing up without causing potential risk for the patient. All right, we're done.
Lights on, please.
All right. So we had to do this with 2 cuts, 2 incisions, which is fine. And that's just because of the prior fusion, but we actually got it done. Scope off, please, guys. Someone's got to turn the scope off. You're going to melt the drapes, okay? All right. So let me show our audience real quick while I'm holding this. Let me show them the tube. For those of you that weren't here earlier, the whole surgery is done through this metal straw. We call it the McDonald's shake straw. And honestly, McDonald's should be paying us some type of a sponsorship money. We mention it so often, you know. I'm sure there's a lot of people that watch the surgery that end up going to McDonald's afterwards to get a chocolate shake or a vanilla shake. But that's the shake straw. How's she doing? And we did the whole surgery through that little tube. And that tube goes down and it goes into the hole. Can you see this?
We can.
It goes into the hole where the nerve comes out, right? So pretend this is the nerve. You see that there? Can you see that nicely?
Yes, we can.
So I go in just below the nerve root that's coming out, and that nerve root comes out and goes down the leg, right? So I go into the hole just below the nerve root, and I fix the disc down here below the nerve root. All right, folks, there it is. Why don't you hold a little pressure? I'm going to head over to the conference room and answer some questions, so feel free to type up any questions you might have, and I'll head over there and we'll do a little more teaching, and then maybe we'll go see our patient who wants to go home and check on him.
We do have a meeting.
No, the meeting can wait. Hi everyone, Dr. Deuk Majin. Thanks for joining us today. It's been a very interesting day to say the least. So we just had a patient who came from Canada, and she has had back pain for 18 years. She has herniated discs, and she had 3 of them. Specifically, she had herniated discs at the bottom, L5-S1 disc, L4-5, and L3-4. By the way, this is the tailbone, and the disc above the tailbone is always the L5-S1 disc. So L5-S1, L4-5, L3-4. We name them based on the bones above and below the disc. That's 5, 4, 3, 2, 1. So this would be the 1, 2, 2, 3, 3, 4, 4, 5, 5, 1 disc. The most common disc to herniate and cause pain is L4-5. That's this one right here. See the white disc right there? And then the next most common is 5-1. The next most common is 3-4. This patient also had screws and rods placed in Canada inside the bone. And the surgeon never took the bad disc out. He left it there. So I went in there today and tested it. And yes, indeed, it was painful. I think it was an 8 out of 10 in pain. Let's see here. 8 out of 10. And it was concordant, meaning that was her typical pain she gets every day. The disc at the bottom of the spine was a 10 out of 10, and the disc above the fusion was a 10 out of 10. So 10 out of 10, 8 out of 10, 10 out of 10. The pain will be gone in her back and legs when she wakes up. I'm excited for her, and hopefully we'll be able to check on her in a little bit. In the meantime, I'm going to go check on the first patient as he's ready to go home and has been chomping at the bit to get out of here. Do we have any questions? All right, it's been a wonderful day. I've had some really good questions and comments today. I look forward to our next surgery day, which I think is next week. What day? Tuesday. All right.